Herekar, adult and child neurologist. I was lucky to speak on the evolution of anti-epileptic therapy with the courtesy of Genetic Pharmaceuticals in the beautiful city of Tashkent, the capital of Uzbekistan and the largest city in Central Asia, which is a vibrant mix of Soviet-era architecture, modern high-rises, and rich Islamic history. We will be talking about the evolution of seizures. Evolution of seizures, yeah. Seizure treatment, evolution of seizure treatment, because हमने बात तो कर ही ली है phenobarbital की. So when we come to the end, we will go through a couple of decades of treatment. शुरू करेंगे. So epilepsy therapy mirrors evolution of neuroscience. This is so important. This statement, the way neuroscience is progressing, amazing. I mean, if you go into neuroscience, it's gone way ahead. This is exactly progressing. So the very treatment of epilepsy is also progressing tandemly with the mirrors of evolution of neuroscience. So we have started, when I started my practice 44 years ago, we have started from something called suppression. यानी हमने दवाई क्यों देनी है? क्योंकि हमने दौरों को suppress करना है, irrespective of what is going to happen in the general sense of the quality of life of individuals. This is how it all started. So this is where it all started. And then, of course, the toxicity that was created by the old-time drugs, which were very, very good at that time, and they were controlling seizures, but they were toxic. And now, of course, from toxicity, we have gone to tolerability. It's so important. When you're treating a child, I mean, you people are so experienced. I'm not talking to youngsters, I'm talking to senior people. When you treat a child, you do not only treat seizures, you treat him to maintain a quality of life. अगर हम किसी को ट्रीटमेंट दे दें और वो घर बैठा हो तो there's no treatment. That's no treatment at all. You have to maintain a quality of life here. So then we go to empirism and mechanism based therapy. What is empirism? Empirism means कि यार ठीक है, दे दो यार, मरीज को ठीक होना चाहिए. It's a very casual term. But now, of late, with so much development, we are now talking of mechanism-based therapy next. So we have started with phenobarbital, we started with phenytoin. I started my therapies in 1982. A few of you may not have been born then. So 82 में जब हमने शुरू किया था, we had phenobarbital, we had phenytoin, and then came carbamazepine, and the best drug that came in later was valproate. तो उस जमाने की बात कर रहा हूं. So what was happening then? There was a global suppression of neuronal suppression. And then what was happening? High sedation, cognitive decline. हम बात कर रहे हैं phenobarbital की. Phenobarbital causes scholastic decline. I'm telling you, 30%, Doctor, 30% of children, you know better than me, 30% of children will have scholastic decline. The schooling is going to be affected. But under the circumstances, जो बात की है कि गरीब आदमी क्या लेगा, I can't argue on that. But you must know this. And of course, the enzyme induction is extremely important. Next. So then we went to carbamazepine, we went to valproate, we went to succinimide, and then of course, and the mode of action was channel blocking, sodium and calcium channel modulation, improve seizure activity, of course. Systemic toxicity persisted. This was bad in the initial stages. Next. So then came lamotrigine, topiramate, gabapentin, which is still being used. This was the third generation rationale, and better tolerability, and of course, indications were more expanded. Next. Then, of course, came the ones that we are using today, the precision drugs, and they were Levetiracetam, Brivaracetam, and then the sympathetic modulation, minimal drug interaction. This is most important. I mean, there was no enzyme induction, and this is important because that is so. It has a very, very important impact. Rapid titration, high safety. Safety is so important. Next. So mechanism का जो shift हुआ है, mechanistic shift जो हुआ है, वो हुआ है from the old ion channel blockade to the sympathetic vesicular modulation, which is today, and network level stabilization and precision pharmacology I've already talked to you about next. So levetiracetam versus the traditional AEDs. No enzyme induction, extremely important. Minimal hepatic metabolism, another very important factor. Number 3, fewer interaction, again important because you're going to drop the levels of other important expensive anti-epileptics. And of course, safety, polytherapy, and of course, morbidity is next. So modern clinical approach was more precise and is precise. How is it precise? Because you know what to use in focal seizures, levetiracetam and lamotrigine. Then, of course, you must know what to use in generalized seizures. The broad spectrum ones, valproate is still an important drug to be used, and of course, levetiracetam. Elderly levetiracetam is preferred comorbidity guide choice. Next. So signature insight, the evolution epilepsy treatment reflects the evolution of our understanding of the brain. जिस तरह neuroscience develop हुई है, उसी तरह the drugs have evolved into something so good that they have a huge spectrum of safety profile. So we go to levetiracetam, which represents a paradigm shift, and then the future. What does the future have? Network and genetic precision therapy. Next. The treatment evolution from barbiturates to today's synaptic science. The journey continues, and I must tell you there are 4 new medications beyond levetiracetam that are now in the US, and we have an epilepsy center there, using those. But of course, levetiracetam still remains the prime drug. It's very, very helpful. Where neuroscience meets precision, this is what's happening next. So what is levetiracetam? Now let's come to the drug we're going to talk about today. A second generation anti-epileptic drug, chemically distinct from other older AEDs. You all know that. Acts via binding to the SV2A synaptic vesicle protein involved in neurotransmission. A mechanism that has not been shared by many older AEDs. Approved for focal and generalized seizures in many countries now. Next. So the key pharmacological advantages. What are the key pharmacological? Why should I use levetiracetam? This is why I should. It has a unique mechanism of action. It binds to just SV2A rather than primarily sodium and calcium channel, where you can have a lot of side effects. Rapid absorption and predictable pharmacokinetics. Little hepatic metabolism and low potential for drug-drug interaction compared with the older AEDs like our carbamazepine and phenytoin. Flexible dosing and wide age range, license for use from infants to adults. Every age can be used. And efficacy compared to other AEDs, evidence on seizure control, larger studies have shown that comparable efficacy to many conventional AEDs, carbamazepine, lamotrigine, randomized trials, proven superior to placebo in increasing or 50% responder rate. Comparison with other newer AEDs, indirect evidence suggests that similar efficacy to newer agents like lacosamide. Of course, you can always combine. It is a very good combination, lacosamide with levetiracetam. And of course, you can also use levetiracetam, but with favorable tolerability at standard doses. Next. So coming to tolerability and safety, which is the most important thing in all anti-epileptics today, it is better overall tolerability. Number 2, lower rates of withdrawal due to adverse events compared to some older AEDs such as carbamazepine. Number 3, fewer serious adverse metabolic. This is very, very important. Of course, less impact on liver enzyme and hematological toxicity in many comparisons. And behavioral and psychiatric monitoring. Some patients may have mood changes, of course. बच्चों में काफी अच्छा खासा हो जाता है, and or irritability, but it needs to be monitored. Next. Special populations of pregnancy and child bearing age, it's important. lower observed congenital malformation rates compared with many traditional. So it can be given, of course. One has to be careful in compared to other traditional AEDs, and generally preferred when possible for international registry, and in pediatric use, suitable for many childhood focal and generalized disorders with evidence supporting its efficacy and safety. For instance, we've all been using it. And practical clinical advantages: low interaction potential, useful polytherapy, especially in adults, or multiple medications. Dose flexibility is very important, beneficial for acute seizure management and titration. Injectables, broad indication, effective for focal and generalized seizures. And in summary, levetiracetam, why should I give it or you should give it? Because number one, it's a broad spectrum. Number two, ease of use and favorable pharmacokinetics. And number three, better tolerability versus many traditional AEDs. Number four, good safety profile in pregnancy in children. And clinical choice should always be patient specific and based on evidence, comorbidities, and of course, treatment goals. So I think we have enough reasons to give levetiracetam. We close it here. We can always ask questions. You're all epileptologists, and I'm sure you have a